glued to the right ventricle, and not kinking the right ventricle and not kinking the right ventricular outflow tract.
And do you use a deep suture then?
No, I do not use a deep suture at all. So we use one of the suction exposure devices, as well as a suction stabilization device. And this is one of the times where it's extremely valuable to have a pulmonary artery catheter in place. Because if a patient is going to tolerate it or not tolerate it, the judgment can always be made, never say always about anything, but can usually be made on what happens to the pulmonary artery systolic pressure. If you see the pulmonary artery systolic pressure going down and the CVP going up, you have impaired outflow to the right ventricle, and usually a simple micro manipulation can restore the normal hemodynamics to it. But that's the first thing we see is what happens to the pulmonary artery pressure, and we make the adjustments accordingly.
Heparinization, full dose, half dose?
We use 3 milligrams per kilogram. And it's about the same dose as we use open, and we fully reverse it at the end of the procedure.
What's your view on reduced dose heparin?
I don't see any reason to use it. The only things that can happen are bad. So
yeah, absolutely. So you've got your stabilization device on. Do you use any slings as well to occlude flow?
So the choreography of doing this is almost always we bypass the LAD first. And early on, our experience was if you had a totally occluded vessel, you would bypass that first because that was kind of a free shot. However, we very early on evolved to doing the left anterior descending coronary first. And the reason for that is that requires minimal distraction of the heart and is usually the most important vessel. So we revascularize that. That is best accessed by just putting 1 or 2 wet lap sponges behind the heart. You don't even need the suction exposure device for that. You just distract it slightly by putting the laps behind the heart. That gives you enough exposure. We then put a silastic loop proximally only around the vessel. And then after we have that in place, do we then put the suction exposure device in place. We do not dissect out the artery until we have all that in place because it's easier to do that on motionless rather than a moving field.
And we've opened the artery, and next we need to place a shunt. Do you have any tips on shunts? They're easy when they're easy, but sometimes when it's very calcified or small.
Yeah, so I have a great tip on shunts. Don't use them.
Oh, right.
Yeah, okay. I never use a shunt. I mean, I realize you never say always or never, but I can't remember the last time that I used a shunt. I think they only complicate the operation. They violate the old Benton Cooley principle of keep it simple. They're hard to get in. It wastes time. You inevitably get the wrong size. It's either too big or too small. You've got to try to sew around it. It's not as easily to get the sutures in, and can damage the vessel itself. So we find the simplest thing is an air stent. In other words, a CO2 blower.
Yeah, and you never put a distal silastic stay if you ever get a lot of backflow, or they
rarely. And the reason for that is one is I'm concerned about damaging the distal vessel, but usually proximal occlusion works. The exception to that is when you have a chronic total occlusion of the vessel and it's all collateral flow retrograde. In those instances, we don't even put a proximal snare on because there's nothing coming that way. We'll put the snare distal to decrease the flow. But the key is a second assistant who is versatile with the CO2 blower can virtually always get you a clear field.
Yeah, and actually performing your distal anastomosis, what suture do you use, and how exactly do you do that?
So I use a 7/0 suture. I used to use 8/0 for mammaries, but I went to 7/0 because the needle is a little bit larger when doing it off pump. And I start on the heel, single suture all the way around, and I start on the far side of the heel and sew toward myself. And while the conduit is not in approximation to the vessel, I put 4 sutures in the artery and then 4 sutures in the coronary, and then pull it down. I then sew the side toward me, go around the toe, and then backhand up the backside at the end.
Excellent. And then at the end, a couple of stay sutures just to hold it down.
So usually one stay suture, usually just for the lima to the LAD. That's the only one that I feel needs a stay suture, and I usually just put one proximally.
So you've done the LAD anastomosis. How do you continue from there?
So then I usually march my way around the heart, and I usually start from the right side and go to the circumflex, so I do the lateral wall of the heart last.
Okay, so you'll do the right and then some OMs, all with the reamer, free reamer.
So a couple things. One is, if I'm using bilateral internal mammary arteries, I usually do the right last, wherever that goes to. If it goes to the circumflex, I do that last. If it goes to the right, I do that last. If I'm only using vein grafts, then I start at the right and go around to the circumflex, because I do think the circumflex is technically the most difficult part of it, and tolerates distraction the least well. So I like to have as much revascularized as possible before I get to it. It also kind of gives me the sense of accomplishment that I've got a whole lot of these anastomosis done. The operation's almost done, and all I got to do is the lateral wall.
Yeah. And it's always the most difficult one, isn't it, that
Yes.
lateral wall? Do you have any good tips about how you really get good exposure, the large LVs, poor LV function? It's sometimes quite difficult to pull those up.
So the poor LV function I don't think is a major issue, but the thickened, hypertrophied, small cavity left ventricles are the ones that are the most difficult. And so I have a secret weapon, and that's what I mentioned at the beginning. It's my anesthesiologist, and there's virtually nobody that we can't access. And that's not because I'm good, it's because my anesthesiologist is absolutely superb. So he knows all the hoops that we have to jump through in order to do it. So the first thing to access the lateral wall is to let down the stay sutures and slacken the pericardium on the right side so that the right ventricle is not compressed. The second thing is put a suction exposure